Go ahead and get started. Hello, everyone. My name is Sarah Neary, and I am one of the social workers here at Oak Knoll. I've been here it'll be 8 years in August. Prior to coming to Oak Knoll, I was a social worker at Iowa City Hospice. And my role at Oak Knoll is generally working in the independent living realm, and then also in the assisted living realm. And so a big part of my job is to help coordinate and navigate transitions from independent living to assisted living or to the health center. And I'm not going to introduce everybody right away. They will introduce themselves as the mic is passed around. I will say that we give this talk a couple times a year, alternating with Steve Rowe's talk about the money part of the whole deal. We talk about the care part of the whole deal. And what we have found after doing this so many times is that there's no way for you to retain, people don't generally retain the information that we share in specifics until it applies directly to them. So just know that if you don't get everything or feel like you still have some questions, you can always reach out to any of us at any time, but another transition talk will be coming around soon enough. So for that reason, and because there's so many of us, we're going to kind of zip through the levels of care at Oak Knoll and our unique roles in those levels of care. And you just heard mine. I'm the social worker for independent living and assisted living. You heard a big part of my role is coordinating and supporting transitions. I work very closely with Allison Clark, who is the part-time social worker here. And I also work with the independent living apartment nurse Stacy Edwards and Scott Wickenteller. The main thing I just want to say is at the independent level of living, the support that we provide is really an amenity. The independent living area is not licensed by any healthcare regulatory organization. And so what we offer is supporting you as you manage your own medical affairs. So just as you go through the levels of care and are needing more assistance, that's when you enter into licensed areas like the assisted living, the health center, the short stay unit, or the lofts. So I'm over at the main campus for the most part, Monday through Friday. In addition to just the transitions work that I do, I also facilitate a couple of support groups. I facilitate a caregiver support group for spouses or loved ones who are caring for a spouse or loved one who has some kind of chronic life-limiting illness. Most of the caregivers that I work with have a loved one who's living with dementia. But people with cancer and other types of life-limiting illnesses are welcome to join the support group. And then I also facilitate a grief support group because being part of the grand cycle of life, people come and people go, and it's important for us to have a place where we can share our losses and kind of share our grief journey. So that's what I do. I wanted to pass it over to Allison so she can kind of share how she shows up over at Oak Knoll East.
Sure. Can you all hear me? All right. So I'm Allison Clark. Like Sarah mentioned, I'm a part-time social worker here. I'm at Oak Knoll about 20 hours a week. I also am a Master's of Social Work student full-time, although I am taking the summer off classes and it feels lovely. So a lot of you already know me because I spend my Thursday from 9 to noon or 1 here at East. So I have already had the chance to introduce myself to several of you. I work at all levels of care, so I work in the independent living level of care with all of you. I also work in the health center. Kaylee will talk more about the health center. I spend a good amount of time in the loft memory care unit and a little bit of time in assisted living as well. One of the things I do here at East is facilitate a peer-led support group called Let's Talk. This was an idea that came from some residents who got together and like a space to talk about anything that comes up with adjusting to living in this type of community. Also issues of aging, health, things like that. It's a really great place to connect with one another and get to know more. The best meetings are the ones where I say the least, and luckily we have some really great participants who attend regularly, so it's a pleasure and a privilege to be able to be in that space. So I am here every week. If you are interested in setting up an appointment with me, I can also be here outside of my regular East hours, or I have office hours here.
So as social workers, we work very closely with the apartment nurses. Stacy Edwards is more full-time over at the main campus, and Scott Whittenkeller kind of travels between the two. So I'll hand it over to Stacy, and she can tell you what she does.
I am Stacy Edwards. I've been at Oakland for almost 15 years. I started in the health center and then became the full-time apartment nurse. Probably however long Sarah's been here. So did you say 7 or 8 years?
Mm-hmm.
I usually say 5, but I guess it's 7 or 8 now. So sometimes Oakland feels like my second home or my first home. I think I spend more time here than I do at home. So what we do on a daily basis is really variable to what's going on in Oakland. Some days it feels like we're just putting out fires or helping prevent them from starting. So we mostly help coordinate, like Sarah said, assisting in you caring for yourselves or coordinating your own care to prevent hospitalizations or illnesses or injuries, and also help assist when going to the short stay or coming home from the short stay to make sure that you have a safe plan in place and enough support to stay in your apartment safely. I also am part of the cancer support group. We meet on the 4th Wednesday of every month. We talk about life within the cancer world and outside and how it affects people, and are always glad to have more participants. Marion Schwabauer leads the group, and I just get to be a part of it. So I mostly learn from the residents that are there, all the new medicine and things that are happening and changing in the cancer world, and so I really enjoy it, and it's a good experience for me. What else do we do? So maybe Scott can fill in more of what he does. We have an apartment nurse available 7 days a week from 7 to 3. I work Monday through Thursday. Scott and I have overlapping hours, and then we also have a weekend nurse. So usually we encourage people to leave a message if you would like to schedule a time to meet with us or just have some questions, and we'll follow up with you as soon as we're able.
I'm Scott Whittenkeller. I've had the pleasure of meeting many of you. And then after we got through the pandemic, saw that we had a need to have more regular nursing here. I now have clinical hours or office hours Mondays, which is from 10 to noon, and then, I reversed that. Mondays are noon to 2, Wednesdays 10 to noon. Most days, Wednesday, I'm here most of the day and available to meet. I'll have appointments with people or I can make appointments. I wanted to just refer to the whole team here, which is what this is, that all of us work as part of the LifeCare promise, and we work together. So if somebody comes to me with a need that seems like a social work could help, I will make that referral and make that connection. If somebody comes to me with a medical need and I have a question, I could also call Stacy and ask her, have you seen this? What do you think? As far as the nursing coverage and what the nurses do, we help refer, we help to connect with the team, but we also answer questions as nurses. If someone has a question about something going on, peel out, as my mom used to say, not feeling right, we are certainly a resource. I just don't feel well, things aren't right. We can do an assessment, we can see if we have an idea whether you need more fluids and a good day of rest, or that you need to look deeper into it. We will help to, after that assessment, we can also look at medicines you're taking, see if there might be involvements. If someone has a change in health that's obvious, and we think you need to be seen, we'll recommend it. If you feel truly unwell, and I always fall back on, in a discussion with someone, if you are concerned that you're not well right now, and you're concerned about your own well-being, call 911. And that's the same recommendation that is given to the main campus. They're very fast to respond. We all pay for it in our taxes. And if there's any kind of life-threatening situation, that is definitely your best choice. If you're just wondering about something that's hanging on, absolutely give us a call. I actually recently had somebody call. We got in touch. I was on the main campus and used an iPhone with FaceTime and did a video call. We could look at images, discuss what had occurred, and it was pretty clear through that discussion that there was no need to go to an urgent care or to an emergency room. And so that's also an option. At times, somebody has a need. If there's a dressing change that is a regular thing every day, I'll leave the main campus and make an arrangement to come here and do that dressing change for that resident. So we are available outside those hours by appointment, or if need be, we will get here. If somebody has a call, if we're unable to, and it requires urgent care, then we would recommend that. I'll go with the next slide.
Thank you, Scott. So what Scott and Stacy kind of described are acute, one-time questions that might, happen over time. We get a cold and then we've got a wound that won't heal. And those are things that they're very comfortable assisting you with. If there becomes kind of a pattern of need in terms of just not being able to manage medications or remember appointments or take care of a chronic condition. You've had diabetes for a long time, but now your sugars are all out of whack, and you're just not managing your own care in the way that you used to. Then it becomes time to talk about a transition to a higher level of care, because the independent world, there's 2 of them and there's 400 of you. And that information, how we assess whether someone's kind of declining, comes through a lot of different avenues. Sometimes it's the apartment nurse that's seeing a decline of someone that they see every week at the blood pressure clinic, and things are just changing over time very slowly. Sometimes we have, other departments, the EVS or dining or, even administration or something telling us, I had a funny interaction with this person, they just didn't seem themselves. So those are, we're all over the place, always kind of keeping our eyes and ears out for leads and observing as things change. And that would kick off, the start of a longer term discussion, not only with the resident, but who their supports are in terms of power of attorney or family members, in talking about transitioning to a higher level of care. And so that's when I kind of start to link Jacqueline Craig in, if we're talking about assisted living, because she is the nurse coordinator for assisted living. So just know that we're kind of glossing over the communication part, but there's a lot of communication that goes with that process of determining it's time to move to assisted living. But I'll hand this over to Jacqueline so she can share what the services are in assisted living once you're there.
Yeah, so once that conversation, well, I should start first. I'm Jacqueline Craig, I'm the assisted living coordinator. I've been at Oakville about the same time as Stacy. I started in 2007 as a CNA in the health center, and got my LPN and then my RN, and then came into this position. So I kind of feel like I dabbled in all pieces of nursing at Oaknall and have experience on all areas, which hopefully makes me an expert now in assisted living. So like Sarah said, you know, I kind of start to hear from the apartment nurse and Sarah when somebody might be needing assisted living. The majority of my position is to really monitor and regulate the rules and regulations for the state of Iowa to see when somebody might be appropriate for assisted living, and then maybe once they're in assisted living, when somebody might be exceeding criteria and needing a transition to the health center. So I like to talk a little bit more about kind of the menu of services. When somebody moves into assisted living, we like to encourage people to maintain as much independence as they're still able to. Most people would prefer that as well. So we kind of focus on a service plan, and it's kind of a menu of services, and I map out the needs that would be appropriate for you, for the staff to help with. So I just like to kind of run through some of those services, and that would include like showers, shower reminders, basic hygiene and grooming reminders, if you need assistance with dressing, undressing, hearing aids, transfers mobility, maybe mobility is declining and you need wheelchair supports to get to hair appointments or activities or wellness opportunities that you're interested in, continence, bathroom needs, food services, assistance with simple meal prep, housekeeping, laundry services. Housekeeping comes weekly in assisted living, and laundry is also provided weekly. Everyone talks very highly of laundry services in assisted living. They take it, wash it, dry it, and hang it up for you. It's like it never even left your closet. Trash removal, doing your dishes. We have a grocery shopper in assisted living who shops out in the community at a couple different locations, and then that just gets added onto your Oaknall bill. So that's a service that some residents enjoy. Transportation services. Transportation right now, I believe, is a cost in independent living and assisted living to and from medical appointments. It's no longer a cost. Medication management, diabetic management, as Sarah mentioned, some of those things are a lot to take on, and it's nice to take it off your plate. So I think that's the majority of it. And then just nursing support, managing doctor's appointments and blood pressures and weights, and kind of just coordinating. I think all of you probably experience a little bit, having multiple physicians or multiple different medications prescribed by different people, and we kind of take it all on and manage it all. Sometimes somebody comes back from urology and maybe their primary care physician doesn't want that medication for them. So just kind of cumulative communication with all of that. So, and again, just monitoring the rules and regulations for assisted living when somebody might be appropriate to transition to a higher level of care. And then I kind of work closely with Kaylee Gilmore, who is the social worker for the health center. So I'll kind of pass the mic to her.
So I was just going to clarify, because Jeff ran through that quick. So as you know, for independent living, there's no cost for transportation. But if you were needing a companion or someone to assist you to appointments, that is an added fee in independent living, and that's a service that it's included.
It's an added fee in assisted living as well. Yeah.
Oh, I think
Companion services.
Not the transportation.
not the transportation.
Yeah, not the transportation.
Hello, I'm Kaylee. I'm a social worker in the health center in the licensed area. I've been at Oaknall for about 7 years. So under the health center, the licensed umbrella of the health center, there are 3 different care areas. I'll just touch on each area here, some bullet points for you to know. So of the 58 beds in our health center umbrella, 10 of those beds are in our short stay unit. So people are admitted to the short stay unit to work with physical, occupational, and speech therapies, and also to receive any nursing support as they recover from an acute medical event or a hospitalization. Maybe someone has a fall and fractures a bone and has it surgically repaired and needs to rehabilitate for a little bit before they return back to their prior level of care. Admission into the short stay unit is determined to be medically necessary by a a physician or a healthcare provider that you're working with. And this can be a little different than maybe just one's desire to spend some time in the short stay unit. So it really is determined as medically necessary. And our team works with you and your family and support system and your physician to determine that if there's any question. So discharge will occur when one is ready after they've recovered back to their prior level of care, or if it's determined that maybe through that stay one needs a little more assistance, or maybe they just aren't able to get back to a prior level of function due to a health condition or medical event, then we start to have a conversation about a higher level of care. So discharge from the short stay unit may include discharge to assisted living or health center, but that's all determined through conversation with you all and your supports and your physician and our team. Sometimes a person's admission to the short stay unit is accommodated in a health center room, just depending on the availability of rooms in our short stay unit. In general, we make decisions as a team, and there are specific needs and circumstances that we discuss on a case-by-case basis. Generally, as I've described, the admission to the short stay unit occurs as I've described, but of course there are circumstances that we discuss with you and as needed on a case-by-case basis. In the health center, we have 36 beds. There are 30 of those 36 beds are private rooms. We have 3 double rooms that we reserve for maybe spouses who want to reside together, siblings, friends. In the health center, we provide 24/7 nursing care, certified nursing assistants, dining services, recreation services, music therapy, transportation to medical appointments, environmental services to clean, laundry services. Residents in the health center are welcome to attend activities and programs at any level of care. Sometimes a health center resident may need someone to accompany them, but we really, if that's important to that person, we really do our best to accommodate that. Want to make sure that someone's routines and preferences and values are honored all throughout the spectrum of care. Medicare requires a care planning process, so health center residents are invited to meet with our care plan team on a quarterly basis. It's a nice opportunity to just kind of touch base face-to-face on how one's care is in the health center, also to express concerns, ask questions, and revise what it is that's important to that person. And then we have a loft memory care unit, and there's 12 rooms in our loft memory care unit. This unit is was designed in a home-like manner and intended to function like a household model of care. There's a common area. We really do our best to incorporate residents, depending on their abilities, include them in the daily tasks of the day. In the past, we've had residents who enjoy vacuuming, so they would vacuum after meals or roll silverware, help set the table. Meals are prepared in the loft, and the intent behind that is to have the smells and aromas elicit memories and kind of stimulate those who have a dementia diagnosis. So admission, there is a criteria process that our team uses to evaluate whether or not someone would benefit from the loft environment versus the health center. And so the evaluation is ongoing. Initially, at the time someone if there's discussion that's occurring that someone needs a higher level of care, But then after someone moves into the loft, there's ongoing evaluation just to make sure that someone really is benefiting from that environment. The loft is staffed with a loft coordinator. There are 2 CNAs, a cook, there's also environmental services, a recreation aide, and a nurse who floats from the health center up to the loft unit, which is just 1 floor above the health center. That's a very quick synopsis of those 3 levels of care, so I'm sure there's questions. But.
Yeah, so I just wanted to just chime in, kind of wrapping all of this up, is recognizing that the healthcare staff to resident ratio as you go through the levels of care. Independent living, there's 2 for 400. You know, assisted living, there's 3 to 30, 33 residents. And then in the health center, there's the ratio increases as the more care that you need. And so, just recognizing where you might fit in that spectrum. What we've seen over the years, or at least in my time, what I've seen is that sometimes people can wait too long to kind of take advantage of that assisted living window. Assisted living requires quite a bit of independence. It's just, kind of extra support, a safety net of support, if you will, with, certain criteria that would disqualify you from legally being able to live in assisted living. And so we have to be really careful about, making sure people are aware when that optimal window for them is wide open. So just recognizing that the reason you moved into Oaknall is so that, those levels of care would be here for you when the time came, but it's often hard to know when the time is here. And so that's why we just encourage this kind of open dialogue and questions about, how do you know, or what the process is like. So that's it in terms of just the brief overview, and we'd love to hear your questions if you have any. Yes.
I'm just curious, you didn't mention food in assisted living. Is any food provided, or is it more like independent?
Yeah, and I'll let Jacqueline, I'm just repeating the question, asking about food, what's the food plan in assisted living?
Yeah, Sarah and I always kind of say it stays the same. There's an extra tacked on fee for the health center. That's a requirement when you move to the health center, but in assisted living, you could maintain the same meal plan that you are doing now in independent living. You do have a kitchenette in assisted living, so you can maintain cooking in assisted living if you prefer. You can get assistance with simple meal prep, or you can go to any dining venue of your choice, get a meal tray delivered. You can get groceries delivered. So I always say it stays about, the same. I would say one added benefit is they do a meal check-in. Dining Services provides a meal check-in if you would like for lunch and dinner. So some people have standard breakfast trays delivered to them, and then they have Dining Services call them for lunch or dinner and say, here is your dining option in the Hope venue. Would you like to order that? Or would you like to, cook on your own or go to a venue of your choice? So it's kind of a way for us to keep track of who's going to meals, if that's something we're concerned about. But yeah, does that answer the question?
Yeah, good, thank you.
Yeah, can you talk a little bit about what would be the criteria that would suggest that somebody needed to move to the memory care unit, to the law?
Yeah. So first and foremost, someone has a dementia diagnosis. And I will start off by saying there are many people who live in the health center, assisted living, and even in independent living who have a dementia diagnosis. So it's not exclusive. But sometimes, depending on the disease progression, there can be some behaviors that start to manifest. Many times people who have dementia will get to the point in their disease process where they They might start rummaging through things, they might start collecting things, they might start to wander into other people's rooms. There might start to be some outbursts, verbal outbursts. So I would say that if there are some dementia-related behaviors that are occurring, that would be, people would maybe benefit from a lower stimulus unit like the loft. We would start to talk about a transition. The health center tends to be a thoroughfare for other disciplines. It's a larger area, it's busier. Sometimes that activity can overstimulate someone who has dementia. So the loft is a quieter environment, more home-like, intended to try and help elicit memories and orient people to their rooms and just sort of maximize their capabilities. Sort of I don't know if that generally answered your question. It's definitely not a black and white criteria process, but rather a discussion.
And correct me if I'm wrong, Kaylee, but I feel like if, because many people with dementia can also have a physical issue. If the physical issue is really the primary concern or takes a lot of care, then I think that tips somebody more towards the health center location.
Yeah, if they're high medical necessity or need for assessment, lots of medication administration, we kind of evaluate both or all conditions and issues and determine the where someone would be served the best. And there have been times where people will maybe really thrive in the loft and get to a point later in their disease progression where they're not benefiting from that environment. Maybe they need more physical care, more nursing assessment. So there have been times where we've moved people out of the loft into our health center, if that's appropriate as the disease progresses.
That's a good question, thank you.
Yes.
Are you full most of the times? I mean, how do people ever have to wait to go to assisted living or to the loft or the health center?
Well, I can talk about assisted living. We have been full. Assisted living is a little bit different process because it's an independent apartment, and requires moving your own things to your new apartment. So I would say that, we're full most of the time. We have kind of an operating wait list for people who have either expressed interest in assisted living or we have on our radar, don't want to go, but maybe we think it would be beneficial. I think a problem that we run into sometimes is when there are apartments available, kind of sifting through those candidates and finding the right fit for the apartment. So, because sometimes the location of the apartment really can impact their success. And so either really trying to get someone on board if a great apartment for their situation opens up but they're not ready. So sometimes timing doesn't exactly line up, but we work with that the best that we can. And then I'll let Keely talk about the others.
Yeah, so like assisted living, the health center has been pretty full lately, although I will say it tends to ebb and flow. So there have been times where someone has needed the health center level of care. They've started out in the short stay unit. It's been determined that they will stay permanently in the health center. Or maybe they've come for a short stay and been admitted into one of the 3 double rooms that we have available. When the determination is made that someone will be staying permanently in the health center, their name is placed on the private room waiting list if we don't have an available private room at that time. And then we just kind of work our way through that list as private rooms become available. Certainly not ideal to have a few movements into the rooms or that waiting period, but we do our best to accommodate preferences and that need.
Thank you. Anything else? Well, we're not going anywhere, so as questions come up for you, or, as you, things might come up for you, changes might come up for you or a loved one, don't hesitate to reach out to, any of us on the team. Thanks so much for coming today, we appreciate it.